Good morning. First of all, I am thankful to AIOS and Chairman Scientific Committee, Dr. Partha Vishwas, for giving us opportunity to conduct this prestigious national symposia on pediatric ophthalmology. I welcome and invite Professor A.K. Amitava, Dr. Pradeep Deshpande, Professor Vanita Singh, Dr. Sumita Agarkar, Dr. Leela Mohan. Dr. Leela Mohan already with me here. Dr. Parikshit Gogate to the dais. So Dr. Parikshit is also here. Good morning. So nice to see you. Thank you so much. So for this session, we have a galaxy of faculty members who are best in their field. They are best in their respective field, and they will be presenting their work and new dimensions, that is what is new in their field. First of all, I will invite Dr. Ramesh Kakunia for speaking on what's new in myopia. Dr. Ramesh is one of the best in the field of pediatric ophthalmology, and on several occasions, or most of the occasion in conferences, I meet him while he presents pediatric cataract on pediatric cataract, although he does all the best possible pediatric ophthalmology. Dr. Ramesh, please. And time allotted is about 9 minutes. So because we have to finish in time also. Thank you so much.
Thank you so much, Dr. Jagatram, for this introduction and having me here. Very good morning to all of you. We are going to talk about something very important to all of us, not only pediatric ophthalmologists, all the ophthalmologists. We deal with myopia day in and day out. So I'm going to talk about, there are some therapies which has come to prevent the progression of myopia. I'm going to highlight on some of them because you can talk about it for 45 minutes. Some of them are controversial. So if you look at the risk factors for myopia, it's multifactorial, be it genetics, near work, peripheral blur, peripheral refraction, light exposure, and also if you see the near work can have some unknown etiology in unilateral myopia, what happens once you patch, and also the severity and the screen size and the illumination. There are many factors. It's almost everything. It's like a COVID. We have something coming on a daily basis. Many people are just to understand that. And we know these factors like outdoors, light levels, whether it's UV light, vitamin D, all of them are contributing towards preventing myopia. If you look at the article, if you open the PubMed today, there are 3,000 plus articles are there. You know, if you have to be updated, these many articles you need to go through. So I'm going to show, because myopia, according to the prediction, this is one of the paper from our institute, we are at 2022 actually. If you look at 2050, close to 50%. That's a prediction of Indian scenario. It's ever rising in terms of the incidence. And once a myope, you are a lifetime myope. It's not that you're going to change. So the effect on the myopia, on glaucoma, cataract, retinal problems are going to continue over a period of time. COVID has given us some insight. Home confinement with the screen time. There is a definite increase in the myopic shift. This is one of the things which is published in early 2021. And also, what kind of light? This is something new we wanted to study. We put the experiment on, red light, blue light, green light, and the white light. What is the effect of this on myopia? Because we are even trying to see light therapy for myopia along with other pharmacological treatment. Towards that end, we started this project. You can see that effect of short wave, that is blue, and the middle one is green, and the red on axial elongation. That's the setup of our lab there with different light. And we have given a washout period of 10 minutes for each of these patients. And you can see the effect on the axial length, what you can see here. So if you see this is a very important chart. If you see the red and green can kind of increase the axial length, blue light is protective towards myopia. That's what we have found in this range of patients. So blue light seems to control eye elongation. We also had developed the in-house product called MyLight. It can even track the light exposure for a child, because they can keep it like that. You can see in that in their pocket, they can keep it. It's a very less expensive instrument, and blue light is shown to be effective in terms of controlling. This is one of the things apart from many things. The next one what is being studied is the reading from smartphone is better or hard copy for the same. Here we had involved little bit older individual. You can see the age range from 18 to 30 years. 45 participants with an experimental study. You can see the effect. This is what we did: occlude one eye and then give them all three: book, video games, and the screen time. These are the three things we have given, and this is the experiment. You can see the lower lag with hard copy on accommodative lag is lower with hard copy, if you can see in this chart. Greater changes in axial length with hard copy. This is something surprising. Many patients and the parents ask, is the screen time better or reading from the book is better? So there is still some controversy. It's not the only factor which is, there could be a combination of. We also checked the the changes in the vitreous chamber depth and also anterior segment length on these things. As you all know, myopia is caused by mechanical theory and also lag theory. That's why checking the axial length and the accommodative lag is very, very important in giving a customized treatment for the patients. So what's really wrong with single vision glasses? You can see if you don't correct both the central and the periphery becomes hyperopic defocus, as you can see. Single vision if you give, see what happens to the peripheral. That triggers the myopia component. And what is desired is central full correction with relatively, if you keep them peripheral myopia, this is good. That's why these three options have come: orthokeratology, peripheral defocus lens, low dose atropine. There are close to 20 RCTs at this point of time. This is one of the study which is shown the efficacy of spectacle lenses with aspherical lenslets. This is what it prevents from peripheral hyperopic defocus. You need to create a peripheral myopic defocus, what you can see here. Highly aspherical lenses, this is one of the paper published in JAMA, is better than mildly aspherical lenslets. So this is what is the mechanism. You can see a multiple holes there with the spectacle multiple lenses. And if you see the low dose atropine, these are the landmark studies: ATOM 1, ATOM 2, ATOM 3, LAMP, first phase, second phase, and the third phase. And absolutely, there is one study from us, our country as well, Indian ATOM study. So these are the landmark studies, what has happened. And if you see this chart, you must know that lower the dose is much more effective in the long term. Higher the dose, it is effective, but in the long term, they can have a greater rebound effect. So when we choose, the LAMP study says that 0.05% is good, but what the ATOM showed is 0.01%. So there is a slow drift. These are all I'm going to skip because I assume all of you know about ATOM 1. This is what is the change in the two groups, 0.92 and 0.40. And this is about ATOM 2. You can see the long-term effect of 0.1% and 0.5% over a period of time. Very minimal side effect. This gave a lot of confidence in using the lower dosage. And then LAMP study came, it's tilting more towards 0.05%, which is a balanced dose in terms of pharmacological treatment for the myopia. So this is what at this point of time, probably more studies are required in different populations. And they also, the latest is the phase 3 report of LAMP study. This study shows that during the third year, continued atropine treatment at any of the 3 concentrations confers better efficacy than stopping it. Over a 3-year period, 0.05% is more than double that of 0.01%, because this is something very, very important for all of us. And a greater rebound effect was associated with higher atropine in younger patients. So these two are the key words we must understand when we customize the patients with atropine studies. So this is Rohit is here. His group did this multicentric randomized control study. This is again saying that 0.01% about in 54% of the patients. So that's 5 years. And also there are studies to say over a period of time which is the best anti-myopia strategy. Anti-myopia 1, 2, 3, 4. What is the cost involved in each of this over a period of time? If you look at this busy graph, the atropine is the least expensive, but it may be balanced against other things. So I would like to end with one more final thing, that there is a group of myopia. We do even eco myopia clinic, because any one of you have cases to present. We have it on a monthly basis. And also there is a customized treatment in the myopia center. Whenever they come, identify the risk factors, then look at comprehensive examination, including vision, refraction, anterior segment, posterior segment, including imaging and all the peripheral refraction and also the axial length. And photography also we do it, and then come to a conclusion, okay, this is the customized treatment for this particular patient. These are the things what is there at this point of time. You have bifocal lenses, you have natural therapy like time outdoors, probably will come with the light therapy also for myopia, various concentrations of atropine, orthokeratology, because I could not cover everything, where exactly it's useful, and even the central distance multifocal contact lens. All of them have a role, but one must customize this treatment for all of these patients. So in summary, myopia can be axial and non-axial. This is very important to establish, especially because I see these drops have been given to every patient. Sometimes the progression could be the lenticular as such. We need to understand that. And there are numerous anti-myopia strategies available. Treatment must be customized to every patient. And low-dose atropine still continues to be one of the safest option in most of the cases, if not all. Thank you so much.
Thank you, Dr. Ramesh, for so much useful and new information in the field. Maybe one
there's a small change in the schedule. We would request Dr. Anand Venekar to come and present, because he has...
Dr. Ramesh, please, I would like to kind of summarize and also have some clarification. So as of now, all the strategies that we have discussed in your paper, the most accepted is increasing the outdoor time and various doses of atropine, preferably 0.05%. And how do we identify a patient like that? You see a child with myopia, then do you observe a progression for say 6 months or 1 year before you begin the atropine, or you see a patient and you begin the atropine?
Yeah, there are 3 categories. One is pre-myopes, where we start the anti-myopia strategies in the form of natural treatment. Reduce the screen time, increase the outdoor activities. Even it applies to astigmatism and even hypermetropes. If they have myope, if there is a progression of 0.5 diopters in the last 6 months or 1 year, we start the therapy. What treatment to start? It depends upon number 1, the axial length. Number 2, whether the patient has accommodative lag. Number 3, whether the patient has peripheral defocus, we need to do an open autorefractometer. With that, we can start atropine, which is the most common. You can also give contact lenses. Second option, that's PAL lenses you can give. Third option is the peripheral defocus lenses, which are available. They are expensive. And the fourth one, it can be a combination of these three things.
So
Depends.
actually, before we begin the treatment at all, we have to observe the child for at least 6 months.
Correct. If you have a documented, they have visited somebody else, you can already see the axial length is increasing. It's better to intervene.
Yes,
as early
that
as
is
possible.
right. So we should have a documented increase
Progression.
in progression. Yeah,
Yes.
documented progression. Right.
Ma'am, we can have the discussion again
Thank
at the end because we have.
Respected Chair, AIOC, thank you for this opportunity. I'm going to be talking about what's new in ROP and mostly in the Indian perspective. So these are the aspects I'm going to cover. We'll quickly get into that. So the new classification came last year in October. I'm not going to delve into the entire classification, only what's new. So there's actually a table in the manuscript, and this is for a free download, on what's new from International Classification 3 compared to the older one in 2005. What's relevant to us? Aggressive ROP. In fact, the name AP-ROP is now replaced by just AROP, showing that the disease can also happen anteriorly. So let's just go, instead of these definitions, let's go to the images that are there in the manuscript. We're also very proud that India was represented in this group. And in fact, these images have come from our country. So a lot of the capillary non-perfusion, a lot of the occlusive type, and the hybrid type of ROP that has been described from our country first has now made it into different subtypes of aggressive ROP. The next thing is the new thing, terminology of regression. So regression can either be complete, whether it is spontaneous or after treatment. Complete regression means that the blood vessels have reached the ora serrata, or it's incomplete. So here there's a new term called persistent avascular retina, or PAR. So PAR is something we'll have to start dealing with, because especially as we start giving anti-VEGF injections, a lot of these, majority of these rather, are not going to vascularize till the edge of the retina, and they're going to remain as persistent avascular retina. What to do with them is another topic all itself. The second new terminology is reactivation. Now reactivation is something that became better and then reactivated. Now reactivation is either most commonly again seen after anti-VEGF. So I think that's important to know. And reactivation can be either the coming back of the disease fibrovascular proliferation, or the vascular signs of plus, or sometimes a completely new sign. And this reactivation can happen in the older site, a completely new site, or at both places. So it's rather confusing, but at the point we have to remember that follow-up is important. New imaging devices, this is again a pride of the country. It is now an CE and FDA approval for more than 5 years, more than 2,000 installations across the world, and this is now coming in with a angiography model. As anti-VEGF becomes an important tool in our armamentarium to treat ROP, and fluorescein angiography is going to play a very important part in deciding which of these babies might primarily be used for anti-VEGF and how to follow up. The other innovations coming from our country are these. One is called the MII RedCam. It's actually a cell phone based. It's not wide field. It is user dependent. It's not linked to telemedicine platforms, but it's useful for photo documentation. A almost similar device is the C3 from Ahmedabad. Again, this has a slightly more adaptable hand piece where you can alter the distance between the phone and the lens. Again, it is dependent on the 20 diopter lens, and so there are these disadvantages. Newer imaging techniques, I'm just going to delve into few. This is an example on the upper left, is a eye that has been injected and incompletely lasered, and you can see that otherwise it looks innocuous. Oh, it's fine, there's not much disease. But look at the angiogram of that same case, and you can tell how active the disease still is. You can see how avascular some areas are and how the leakage is still going on. This is some work that we've been doing on OCT. Handheld OCT has really helped us understand fovealization, or that process of the foveal dip occurring somewhere between the expected due date and about 52 weeks. So in the first 2 to 3 months after birth, after the due date, the foveal, so-called foveal reflex or fovealization should occur. Now, about 20 to 30% of these babies, and these studies have been now replicated across the world, come up with this, what is now called macular edema of prematurity, or MEOP. Now, this is transient. It can usually happen between the 34th and 42nd week, but its effects last for a very long time. In fact, when we followed up these babies for a year, we found that these babies are sort of disadvantaged for lower vision measured on telar acuity, and also have slightly higher chance of being hyperopic at the end of the first year, even though the edema was just for a few weeks. So why and what? All these other layers will also tell you. For example, the non-fusion of that inner limiting layer with the outer plexiform layer, that blue arrow, and some other changes in the outer retina can all happen when clinically these maculas and foveas look normal. This was our foray into OCT angiography. This was the first time we did it on a really tiny baby with the baby held up. And what we showed here was that now that we are able to image the deep vascular plexus, we find that this so-called flat new vessels of APROP or AROP are actually deeper. We went on to look at what these OCT angiography findings look on for slightly older children. On the left are control babies who've never had the disease. In the middle are those babies who've had the disease and have had 6/9 or better vision after laser treatment, and these are all age 5 to age 10. And you can see how the FAZ is completely obliterated. So they're clinically normal, their vision is normal, and yet their foveal anatomy is not normal. And this is picked up on more sensitive imaging techniques like the OCT angiography. This is one of our theses of our students that has now got published, where we looked at contrast in a baby during ROP screening using these special contrast cards, and we linked that to poorer vision. So children who've had lower contrast or impaired contrast during the initial screening phases have actually had higher chances of developing ROP and have had poorer vision in the 3rd and 6th month after follow-up. So how does this contrast, which is supposed to be a macular phenomena, mimicking what's going on in peripheral avascular retina and then eventually coding for what the disease may be, is very interesting, unanswered research questions. As far as predicting ROP is concerned, we've been doing some work with our basic science lab in Bangalore, where we have taken these tears of these babies, and you'd be astounded that we can get tears in babies who've still not developed their lacrimal gland secretion. And these tears are now analyzed in our laboratory for about 10 molecules. Some of them are pro-angiogenic, some of them are just inflammatory mediators, and we've now come to a point where we can predict which of these babies, based on their first tear secretion, will eventually develop the disease. What we are hoping to do is prospectively figure out which of these babies will end up requiring treatment. You can imagine how useful that will be. In the first screening itself, you take their tears, and then you can tell the mother, look, your baby has a chance of developing ROP 4 or 6 weeks later. This is work in progress. The initial part has been published in IOVS. I want to talk about a little bit of the legal aspects. It's so important. We have a publication coming out of the Indian ROP Society. This is now available for a free download in the APJO. These are about 6 cases that have gone horribly wrong in our country, right from about 24 lakhs to 1.8 crores that went against pediatricians, and in one case against the ophthalmologist itself. What we hope to bring out in this publication is how you can prevent that litigation. Now, this is obviously not foolproof, but some of the pointers are here in terms of consent. What is an ideal documentation? How do you safeguard yourself based on the kind of practice you are in, whether you have a camera or not, and what kind of documentation you leave in the inpatient file, what you give to the parent, and so on. I'm really rushing here because this is up for a free download. I just want to end probably with what we changed during the pandemic. The Indian ROP Society came out with new guidelines. What we didn't change is who and where to screen, but we did modify the patterns of when we can call these babies for follow-up. And I believe that we were one of the few countries that managed to continue ROP screening despite, even I'm talking about, in the first wave. And I think it's something that we're very, very proud of. In the last week of March in 2020, the IROP Society came out with guidelines, and which was eventually inculcated into the AIOS guidelines for other diseases as well. So what we changed was we brought down the threshold for when we need to treat. We said how the follow-up can be modified, and this is our team here trying to treat a COVID positive baby. And look at the date, it's April 2020, when we just went into the first wave and we had no clue what this pandemic was all about. I'm going to end with artificial intelligence and ROP. So again, some work we've been doing in Bangalore initially was just image enhancement, trying to look at these poor quality images better. But today we now have an ability to look at these images in a AI model. We are able to now predict which of these, you throw in the image into the AI model and it's able to tell whether there's disease or no disease. If those who attended the ROP session just prior, this was being discussed. Now what is work in progress is that the sensitivities are here, they are in the early 90s, and we hope to improve that in the times to come. Thank you very much for the opportunity.
Thank you, Dr. Anand Vinekar, for excellent presentation. Dr. Anand Vinekar, he did MS from PGI Chandigarh, so he was our alumni. And Professor Dogra, he did all the training in ROP from Professor Dogra. And from Narayana Netrale, he is among the top in the, I think his outstanding work is globally recognized. Thank you so much.
Thank you, sir.
Thank you, Dr. Anand, sir. Anand always floors us all with his presentation. So
We come to the next presentation, and I invite Dr. Rohit Saxena from AIIMS, Delhi. He would be talking about what's new in paralytic strabismus.
Thank you, Dr. Vinita, and members on the dais, and particularly AIOS for giving me the opportunity in this wonderful symposium. So I'll be talking about what's new in paralytic strabismus. And truly speaking, I would say that the era of, or the period of pediatric ophthalmology is now coming, and of course retina, cornea will continue to grow and develop. But pediatric ophthalmology is now in its most exciting and evolving phase. And besides what all day we've been seeing wonderful research and development in ROP and other diseases, strabismus surgery also has showing great evolution. So I'll just discuss a very small component of the huge changes that we are seeing evolving in strabismus surgery. I'll talk with some of the palsies that we are looking at. So third nerve palsy, among the new things over the past 10 years and recent last couple of years, the major development is happening is in the management of third nerve palsy. The early thoughts were on lateral rectus anchoring to the lateral orbital wall periosteum with a medial rectus resection, evolution of various types of globe fixation procedures to the medial orbital wall, and then finally the transposition procedure of the lateral rectus on the nasal side or the medial side to bring about great correction. So this is the diagram showing the lateral anchor to the periosteum of the lateral orbital wall, which is accompanied with a medial rectus resection. This is usually done in eyes which have some amount of medial rectus function. So you can see that there is some medial rectus function here. Contrast the abducted to the adducted position, and some amount of MR function is there. And on doing that, you can get a fairly good alignment. So of course, you don't get good motility, but you can get fairly good alignment. So again, another patient, you can see a moderate amount of eye movement that is happening when the patient moves from one gaze to the other. And here in this case, you can see it was not so great because the previous movement was not so great. So only a small amount of movement was seen. So if you see fairly good movement, you know that this is going to be a very effective surgery. The next was evolution of the medial periosteal anchoring, and it started with using the DCR incision or tying up or fixing it to the medial orbital wall through a DCR incision, and then we moved to and found it more comfortable to use a precurruncular incision, so there are no skin sites visible. The rehab is very good. It's a potential space, so you can very easily approach the medial orbital wall. So you can just open this. Can I get a pointer, please? So you can open the skin and conjunctival junction that is there. It's a potential space. You just spread it out. You don't even need to really cut it. And you can reach the medial wall periosteum. You can pass non-absorbable sutures. You bring them out from adjacent to the medial rectus, and you can tie them there. The advantage is that you usually will do a lateral rectus recession along with that, especially as the FDT is usually tight. But the advantage, like I said, is that the only one muscle, that is the lateral rectus, has been operated. The medial rectus is free. So if you have associated vertical deviations, you can correct for that. So this is one of the patients you can see who was operated with the same. A large lateral rectus recession was done. You need to make sure that the FDT is free. And you can see the post-op correction being very good. Of course, you do not get any motility because the eye is fixed in primary position, but at least straight ahead, the patient does not have any diplopia, or if the vision is poor, has good cosmesis. So again, another patient you can see, this provides very good long-term alignment. In fact, now I've had patients following up over years who haven't gone back. There is an initial drift that is seen as probably the periosteum gets slightly lifted because of the traction, but provided you do a good lateral rectus recession and make sure that the FDT is free, you would not get a late lag. So again, another patient, you can see that with crutch glasses, the child looks almost completely okay. The next development happened was the medial transposition of the split lateral rectus. And in fact, past 1 year, a world group has under Linda Dagi, Ankur Shah, have actually come out with 3 publications on pooling data from all over the world on the medial or the nasal transposition of the split lateral rectus. This is one of our early publications where basically we wanted to show was that the split of the lateral rectus should be more than 20 millimeters. It should cross the globe so that the 2 split ends can nicely wrap around the globe and come to the nasal side. So this is one of the patients we had done a complete third nerve palsy. You can see that the alignment due to this procedure was very good. Again, another patient showing very good outcomes post-surgery. Now, sometimes you will see that in third nerves, besides the exotropia, you have a significant vertical deviation also. Now, if it's a mild vertical deviation, you can get away with a split lateral rectus transposed nasally. But if the vertical deviation is significant, like in this case, we shifted to a full tendon medial transposition. So a full tendon transposition was done in the direction from opposite to the vertical deviation. So this is an exo with a hypertropia. The lateral rectus was shifted from inferiorly. So underneath the inferior rectus, inferior oblique, shifted and sutured to the nasal side, just underneath or sometimes even over the medial rectus. Here you can see the good correction. Great vertical correction, but not so great horizontal correction. And we've realized that in full thickness transposition, you need to go in again and do a little bit of medial rectus plication. This is just showing the opposite, the exotropia with the hypotropia. And here the lateral rectus was shifted from the superior root. And again, you can see very good vertical correction, but not so great horizontal correction. The only problem with the LR to MR is that it's a non-adjustable fixed procedure. Although extremely effective, it cannot help us to control all the various deviations that can be possibly seen in a third nerve palsy. So while there was one previous publication by Ankur Shah on adjustable nasal transposition, we realized that it allowed us to recess these split ends, but we could not advance them. So in case you have an undercorrection, you would have to tackle the medial rectus. There would be no option. So we did the enhanced adjustable nasal transposition of these split ends, and basically the concept was the same as for the fixed transposition. The lateral rectus is split into 2. This is the image showing the first one, A, showing the superior arm going underneath the superior rectus, superior oblique, getting sutured to the nasal side, and this is the inferior. But the difference was in the image C, where you can see the inferior split end is being sutured superiorly on an adjustable sliding noose knot, and the superior split end sutured onto the inferior part with a sliding noose knot, and intra-op adjustment was done, and here you can see very good alignments. Just quick on 6th nerve palsy, again exciting times for 6th nerve palsy. We now know that there are a lot of options, particularly for transposition surgeries. You can do VRTs, complete muscle transpositions, partial transpositions, and the Nishida vessel sparing procedure. We had done an analysis, a systematic review of all these options, unfortunately, of all the data that was available in published literature, and tried to kind of see what is the best and the most effective. We realized that partial tendon, double VRT with posterior augmentation with a medial rectus recession provided a very significant effect, comparable also with the single muscle VRT, a superior rectus or an inferior rectus transposition with posterior augmentation with medial rectus recession. So this was very effective. Unfortunately, Nishida did not have enough papers for us to analyze, and this you can see the great effects that you can have with partial VRTs with medial rectus recession on the adjustable. This is a patient on which we had done the Nishida with the MRC, and now we realize that the Nishida can be made adjustable by doing the adjustable part on the medial rectus. So you do a Nishida, you get good transposition effect. Along with that, you do a medial rectus recession on an adjustable, and you can get very, very optimal results on the surgery. This is just a child who had a congenital inferior rectus palsy. You can see that there is no inferior rectus here to the globe. You can see the muscle posteriorly, but it's not reaching and inserting onto the globe. And we did an inferior Nishida, which is actually now neatly called belly transfer. So an inferior Nishida of the lateral and the medial rectus, and you can see great correction, including getting some amount of depression. So you're able to get some movement in the opposite gaze by doing a Nishida. A quick wrap up for the inferior oblique, for the superior oblique palsy procedures, Elliott and Nanking, and the infero-nasal transposition, which is one of the most effective, I would feel, surgeries now for superior oblique palsy. So infero-nasal transposition, you transpose the inferior oblique from the inferotemporal quadrant to the inferonasal quadrant, turning the inferior oblique from an elevator to actually a mild depressor with an encyclotortor. So actually trying to mimic the action of the superior oblique. You get great torsional changes up to 12 to 15 degrees correction is there in this surgery, and you can see very good correction, very good, even where there is significant SO under action, you can see some amount of apparent SO action. So these were our results with IOANT with SO palsy. You can see the great torsional change that is there. And of course, Harada-Ito, the only major modification is that now we like to do the Harada-Ito on an adjustable. So where, like in this case, bilateral SOP, we had to do a bilateral Harada-Ito. We did the fixed Harada-Ito in one eye, followed in the subsequent OT by an adjustable Harada-Ito, adjusting intra-op and also getting the opportunity to adjust post-op if required. So these were very great outcomes. Finally, imaging techniques are really changing. We have dynamic MRIs in conditions where we want to understand what's happening to eye movements, and now we're seeing a lot of abnormal eye movements. You can do a dynamic MRI to get an idea of where which muscle is acting, and you can do targeted surgeries or transpositions to get great effect. Of course, high resolution MRI can help us to understand paralytic or restrictive strabismus, and now of course ASOCT and UBM can help us to plan in resurgeries and get an idea of what's going on in these muscles. So like I said, very exciting times for strabismus and pediatric ophthalmology, and thank you very much for the opportunity.
Thank you, Dr. Professor Rohit Saxena, for making this difficult job easy with your dedicated work. So many demonstrations, so many publications you have demonstrated. Excellent work.
Thank you, sir.
Thank you, Rohit, and you have really done a very comprehensive coverage of the subject. And well, there would be so many questions, but just to ask, just to first of all highlight that the newer imaging techniques are helpful, particularly to understand in the complex motility problems. The actual movement of the muscles you can see in dynamic MRI and ASOCT also for reoperations. But one question that I have, that I would like to clarify, that when you are wanting to do a lateral rectus periosteal fixation for third nerve palsy, you also have the choice of doing a very large recession. I mean, also almost like making the lateral rectus non-functional. Have you identified some indications for choosing one from the other?
Ma'am, if the lateral rectus is very tight, the thing is that we actually do not want the lateral rectus to be there. If you severely recess it, it may actually act like a retractor. The other thing is passing sutures so far back can be a problem. And even if you let it be on a hangback, it's more likely that it'll get stuck onto the globe. So I would say, if it's of course a very severe or a very tight lateral rectus, I would prefer a periosteal anchor, especially as it is reversible. So I have had actually reversed a periosteal fixation of the lateral rectus in a case of Duane's actually, and because I got a consecutive ESO. So highly reversible, and of course it eliminates the lateral rectus completely.
That is exactly what I wanted to point out, because doing a very large recession of the lateral rectus sometimes is more tempting, particularly for the beginner, because they don't want to go in and do a periosteal fixation. But both the problems may arise, that the retraction of the globe and also the lateral rectus may kind of refixate and pick up the action. So a periosteal fixation is a good option. And it gives us results, and well, I have never had the opportunity to do reverse it, but as Rohit is saying, it can be easily reversed. So we should try it.
Thank you, ma'am. Thank you very much.
Thank you, Dr. Rohit. Wonderful. Okay, now I call upon Dr. Suma Ganesh, my dear friend, the Director of Academics in Shroff Eye Hospital, to talk on what is new in amblyopia. Over to Dr. Suma.
Respected chairpersons and my dear friends, I would be speaking on updated amblyopia. After all these stalwarts speaking and with so many publications, I am really feeling it's because I don't have a publication in amblyopia. But it's a treat to watch all of them. So I'll be just going to the what practical approaches we have in treating with amblyopia, means over the years. So all of us are aware of the definition, but I think all cases we have to see that whether there's a unilateral or a bilateral decrease of visual acuity, which is basically caused by a deprivation of pattern vision or abnormal binocular interaction, for which no cause can be detected by physical examination of the eye, and which in some cases can be reversed by therapeutic measures. This is what exactly the definition of amblyopia is. And it could be strabismic, stimulation deprivation amblyopia, anisometropic amblyopia, meridional ametropic and combined strabismic and anisometropic. So we have all, from the last so many years, we have worked our practice on PEDIG because most of us have been along the PEDIG studies. And how well do glasses alone treat amblyopia is one question. Do we really know that patching works? How many daily hours of prescribed patching are necessary? What happens when patching is stopped? Does atropine work as well as patching? How often does atropine need to be used, and does patching work in older children? So these are the few of the questions which in practice we all want to know. Yes, refractive correction, I've seen in myself that please do not start patching therapy before refractive adaptation. Give them time, 2 months when you're giving the glasses. Let them wear the glasses for 2 months and we could review them after 2 months. And then we see that most of the time the children do improve. So there is, if patching is needed, then we need to do patching only after 2 months. So we wait till 2 months before starting the patching. So now when do we give glasses? Now all of us talk of amblyopia and patching therapy, but it is not an easy thing to do, the patching therapy in children. All of us doing pediatric practice knows that how difficult it is to even patch, and the amount of torture and the trauma the parents and the children suffer. So can we prevent amblyopia? Something we should all work on. When we see babies, please don't say we can't do the vision, we can't do the refraction. I think we all should have in our clinical practice enough tools to do the refraction, to do the vision assessment. So we should know the guidelines. So this was in a consensus where we all attended, and Dr. Santan Gopal is here, and Dr. Rohit and Dr. Pradeep Sharma, sir is not here, but we all met. There was a group of 33 pediatric ophthalmologists, and on that occasion in 2020, we published the guidelines for amblyopia therapy. So it is slightly different from the American guidelines. So it is myopia if less than 1 year, and if you get the refraction of more than -3, we need to prescribe glasses, and 1 to 2 years more than -3. So this is something we should remember, that we should prescribe glasses in these children. Don't say that the child is too small and we can't make the child wear glasses. Hyperopia more than +4. Hyperopia with esotropia, we put it as 1.5. Though American guidelines say 2, we have come with the consensus that we should prescribe in more than 1.5. Astigmatism more than 3, and more than 2 when the child is 1 to 2 years. So this is how we will, in a pre-verbal child, we will give glasses and prevent amblyopia, so at least they don't have to do patching later. What is an anisometropia more than 3? Hyperopia even 1. I would say here we have put as 2 and 1.5. But I would say that even if you find a difference of more than 1 diopter, we should prescribe glasses. Oblique astigmatism, if you get, even if it is 0.75, we should prescribe the glasses to prevent amblyopia. So what is the diagnostic criteria? It's, of course, asymmetric resentment points towards poor fixation in contralateral eye. The fixation preference we have to see. And preferential looking chart. So now we have the TAC. Of course, these are expensive, but maybe we could use the LIA symbols, which are not very expensive, and use them to do the vision assessment in these small children. And so the best corrected visual acuity we should test on optotypes. Of course, these are for more than 3 years of children. So then when we get to do the occlusion therapy, which is most of the time which the children present, patching is still the gold standard. Please do not go to dichoptic exercises and to other treatment before starting patching. Because I still believe that patching is the only, because we have done a lot of software programs without patching, and we have found that it is maybe when the child has already done patching and you want to start it, it's good, but it is not the primary goal of treatment. For a severe amblyopia, it is preferable still to go for a full-time patching, especially when you have to do, if there is a strabismic amblyopia, esotropia, and I want to operate early. It is better to do a full-time patching and get the vision improved, and then go ahead for the surgery after you find there's a 2 or 3 line improvement. So, and for a moderate amblyopia, you can do up to 6 to 8 hours patching, or we can even do 2 hours of patching with intensive near work. So is there any alternative? Parents are always, children are not willing, parents are crying, and there's a lot of social distress. So penalization, I've used it rarely, but most of the time what happens is that it's in severe amblyopia, and I do not find the normal eye vision being, even if you penalize the eye, still the normal eye vision is still better. So, it means it doesn't work, and then only I think it works in moderate amblyopia. In severe amblyopia, we tried. The vision is still better in the normal eye, so it does not work well for severe amblyopia. Pharmacological agents, ceticoline and carbidopa. So this was a nice paper. In fact, we had a nice webinar with Prachi, and she said that she had published a paper in 2014 and worked on the effectiveness of addition of ceticoline to patching in the treatment of amblyopia around visual maturity. So it was a randomized controlled trial where she took one group where she had only patching and the other group with the ceticoline. And they found very good results. Not in the first 5 months, that's what she said. You have to wait for 5 months before the effect comes of the treatment. So you have to wait, give the treatment. So in the first 5 months, you do not see any improvement between maybe the patching group, you'll get a better improvement. But after 5 months, she found that, and up to 12 months, there were significant differences in the visual acuities in these two groups at the respective intervals. So ceticoline is an option. Liquid crystal glass it was in between, it had come up, and I remember we had used it in 2-3 children. But I think it was more, it is not, I don't know, it didn't cosmetically acceptable, but I didn't think it proved its value because a few parents took it and then I think it was not working. So there was no proven studies also on the long-term outcomes. So the new modalities are the dichoptic exercises, because now what to do? So video games, there are 3 approaches to improve visual acuity. You play the video game with a non-amblyopic eye patched in order to improve aspects relating to crowding. The second method uses it as an anti-suppression strategy, where the same background is presented to both eyes, but an enriched foreground is presented to the amblyopic eye. And the third strategy is to play a video game specifically designed to develop stereopsis. So there's no financial interest, but this is what we had used, so I'm presenting it. So INET amblyopia program, this was what we used. We used the principle of operant conditioning and behavior modification. And in this, patients began, we need a vision more than 660, otherwise this doesn't work. 660 to 636, the targets are there, they can be easily seen. And they become progressively smaller as therapy progresses. Oh, so fast. So we did the evaluation of this, and we found it was effective. We did a study with 63 children, and we did one group with only INET and one group with INET and patching. And we found that it improved, all the lines improved in all the different types of amblyopia. So there was significant improvement in visual acuity by using the INET exercises. But this again was monocular actually. So then we started the dichoptic therapy. And the dichoptic advantages are it is useful for adult amblyopia, faster effects and better compliance. We use the Binox also, and the Binox is, we did a study with Binox also, and to see what are the effects of Binox software program. It was effective, but we found that in strabismic amblyopia, you need to have the eye ortho. So you need to give so in very high degrees of strabismus, we could not give the Binox therapy. So if we could give prisms in the glasses, if a small amount of EXO or EXO, and then do the therapy, it was found to be effective. Now Revital Vision is the new modality, and they seem to be working on the perceptual learning therapy program. And they have found good results. I have not used it personally, but I have been I've met and with Dr. I think Savleen is using it in PGI, and Dr. Sumita is using it in Shankar Netralaya, and they have found the studies itself say that they have got good results. We are going to try it now because there is also an improvement in the contrast sensitivity, and they feel that the vision has drastically improved. Of course, we have our own star, Dr. Sandan Gopal, who has published a paper in IGO on looking beyond occlusion, a novel perspective for amblyopia treatment. It focuses on visual attention and it's an orthoptic magnocellular stimulator. I've seen few results and they are very promising. It improves the stereopsis, visual acuity and hand-eye coordination irrespective of ages. Thank you.
Thank you, Dr. Suma, for that wonderful talk. A very difficult topic, yet still we don't know about the prospects of treatment with as new modalities like Ophthal are coming up. I think there is a lot more area to try, especially in adults. That is the age when they come. 20 years, 22 years, they come and say, we are recruited for something, but some job, but amblyopia therapy has a lot of potential in this age group. So, wonderful talk. So, let's go to the next topic.
I would just like to highlight one thing in Suma's talk. That's okay, you be there. That the 4 to 6 hours of patching, actually 4 hours of patching has been recommended by PEDIG ATS studies. That is for moderate amblyopia. And as you rightly said, when the amblyopia is severe, then we have to resort to full-time occlusion with all its practical disadvantages. And very often it is a good idea to use the school vacation time to do this. Otherwise, the parents are not very willing to accept full-time occlusion, which is the only answer for severe amblyopia.
I would just like to know anybody who's using Binox. We have done a few cases, but not very much convinced to proceed further. Sir?
It works well in situations where patching works well.
Yeah, I think Dr. Vaimbe has a
Yes,
paper.
but if you have problems with patching, yes, Binox is a good alternative.
So the results in anisometropic and ametropic amblyopia are good, and interestingly the stereopsis has also improved. But you know, whenever any new treatment comes, there are always two theories. One is you always go behind it, it's a novel treatment, it's the gold standard, and on the other side you just shun it away, it's not going to work. So I think as a scientific community we should evaluate, it should stand a test of time, and I think we should evaluate on the robust statistical methods. So for 4 months the results were statistically significant only in these two categories, and I think it would be interesting when I see the results of these 275 patients. So the next year I think I should be able to tell you. Right now I don't know.
Thank you. That's a good number. I think we have to be very selective in choosing the patients.
Dr. Parikshit helped me in evaluating all these results. So thanks to you.
All your patients, sir.
In the interest of patient, I think we will let, it's my pleasure to introduce Dr. Sandan Gopal, who actually does not need any introduction. Very uncharacteristically, he is talking on something which is not his, probably the strength, but they're all his strengths. Yeah, true, but I think of late, amblyopia has taken a lot of his time, and
okay.
but he can do justice to any of the topics in this whole symposium. So I'm going to ask him to talk about what's new in competence establishment.
Thank you very much, Sumita, and I am thankful to the AIOC for all this invitation. I'm going to talk about something different. You have to be different. So I talk something different. I'm sure you all have treated all these patients, esotropia, operate on medial rectus, exotropia, operate on lateral rectus, blah, blah, blah. But look at this child. She is cheating you. Huh? Can you see this child? You take one look, you think, straight-eyed. But then draw the attention of the child. So there is something there. So what I am trying to look at this child. Initially, with glasses, there is a head tilt. I thought, no problem. This must be DVD associated. After some time of wearing glasses, the eye goes the other way. So what is it that makes these children look different at different times of the day? The thing which makes them look different, I'll come to that in a few seconds. Concomitant esotropia means associated with squint. It has no meaning. The ophthalmologists have understood the meaning of concomitant differently compared to what dictionary says. Concomitant means the squint is same in all directions of gaze. That's all. That's all we have understood. How often the squint is same in all directions of gaze? Never. If you look up, the eyes go out. If you look down, the eyes go out. And if you look nearer, the eyes come in. So it has no meaning at all. So we need to redefine everything. We need to redefine amblyopia. We need to redefine squint. We need to redefine the whole concept. Okay? Now that's what I'm coming to. As a clinician, you are happy. Esotropia operate on the medial rectus. Have you ever proved that in esotropia the medial rectus is strong? Never. You are operating and somehow the eye is getting straight and somehow the brain compensates for all your mistakes and the eye becomes straight and they become binocular also over a period of time. And so, what is it that I am doing with orthoptic? I am doing with orthoptic few things. Number one, I am trying to draw the attention of the attention center in the brain. There is an attention center in the parietal lobe in the brain. So by using orthoptic, I am stimulating the attention center in the brain via the magnocellular stimulation. The magnocellular pathway stimulates the attention center in the brain, and when the eye makes a saccadic eye movement reflexly, a part of the thing goes down into the occipital lobe and stimulates the occipital lobe. And this part which is coming down is what is called as top-down impulses. Okay? This has never been used ever in the treatment of amblyopia, and they have never looked at it properly because the attention center has received least attention. Somehow or the other, for so many years, the attention center has not received any attention at all. If you do this, the attention center improves. You pinch the ears, automatically the attention center improves. So what happens is, in the parietal lobe, there is a sensory motor integration. So squint is essentially a problem of sensory motor integration. Okay? And I have stopped operating on intermittent divergent squint. I have stopped operating on dissociated vertical deviation. And esotropia gets reduced by more than 50% in many of the patients, so I need to operate less on esotropia. I have stopped operating on fourth nerve palsies altogether because the head posture improves with orthoptic treatment and they are symptom free and they don't want surgery. I have lost money because I don't operate on them. I have stopped operating on acquired sixth nerve palsies and do all those things, do this, do that muscle, bring it here, bring it there, because the top-down impulses travel to the superior colliculus and then they go on to the sixth nerve and improve the amount of the squint. So don't be under the impression orthoptic only treats the sensory aspects. No, it treats sensory and motor aspects, and that happens because in the parietal lobe there is a sensory motor integration which happens. Not only sensory motor integration but also sympathetic and parasympathetic integration happens in the parietal lobe. And many of the cerebral palsy children, what I have noticed is their drooling disappears within 1 week of orthoptic treatment. I never understood why should drool. The patient came and told, mother said, sir, I don't know what magic you have done, she is not drooling anymore. I said that doesn't make sense to me. Then I went back into the literature and then I realized in 1985 there is a paper by Ayres sensory motor integration theory from France. She is not an ophthalmologist. She wrote that there is a homogeneous stimulation of, say, sympathetic and parasympathetic stimuli once the parietal cortex is stimulated, and therefore if the sympathetic overaction is more, the child will cry and scream. If the parasympathetic overaction is more, the child will have drooling, and because of the homogenization of these two, the symptoms disappear. Amblyopia is essentially an attention deficit disorder. So what I am trying to do with amblyopia treatment is to improve the attention of the attention center in the parietal lobe. Yesterday Pradeep asked me, "Arey yaar, tum kya bol rahe ho? Magnocellular cells ko aur parvocellular cells connection kidhar hai?" I said, very simple. It is there. It is there in the parietal lobe. Parietal lobe is connected. And when the magnocellular cells are stimulated, there is an early parietal cortical activation even before the V1 gets stimulated. So what it does basically is it top-down impulses makes the magnocellular and parvocellular cells come in a sequence. The stimulation from the retina should go to the occipital cortex within 150 milliseconds of the top-down impulses coming from parietal lobe. Then there is a rapid fast forwarding of impulses from the V1 to the temporal cortex, and therefore the vision improves. With orthoptic, the vision improves within 2 to 3 sessions, the vision improves. Maybe not 6/6, but certainly it improves by 2-3 lines. You will be surprised, after one treatment, suddenly child reads 618 line from 660. What is this? Is this some magic? No. That is the brain working. It is the brain. So what we have always concentrated on is on the visual acuity value of the receptor, and we have concentrated on the directional value, but we have never bothered about the motor value of the retinal receptor. This is what improves in the motor aspect of treatment in orthoptic. That's why the squint gets reduced. Intermittent divergent squint, you have so many indications for operation. Nowadays, I have stopped operating intermittent divergent squint because they don't need surgery at all, except if they have a marked inferior oblique overaction. That also I have my own doubts whether they need surgery, but over a period of time, I will let you know. Fourth nerve, I don't operate at all. It's so very easy to do the inferior oblique recession, but I have stopped operating on fourth nerve. Sixth nerve also I have reduced. And the only way, last point I would like to say is this is how an eye causes problems throughout the brain in amblyopia. So we have been looking at only eye and a part of V1. We have never looked at the extra striate area which has much more problems due to amblyopia. And there are motor aspects to it. And one last thing. We have not paid attention to the attention area. And lastly, where is that? Okay, he has not updated it. Okay, these are the things which I have been doing perfectly all right. And magnocellular stimulation leads to early parietal lobe stimulation, and this in turn stimulates the attention area in the parietal lobe, and the stimulation of the attention area in the parietal lobe in turn stimulates the V1 at level 4C beta, which receives the parvocellular input. And if the parvocellular input received by the level 4C beta comes within 150 milliseconds of the top-down impulses, vision improves rapidly. Now, patching works because of this, but in patching, the ocular movement is not necessarily so precise. When you patch the eye, this eye may be moving randomly, and occasionally it may come before that, and so the vision improves. Thank you very much.
Thank you, sir. You made us all think differently, and yes, think a lot. And I'm sure this room is full of pediatric ophthalmologists, all eminent pediatric ophthalmologists. So a lot of them will take your thoughts forward, and we will see more research on this.
Incidentally, I've sold more than 65 machines, and many people, Shreya is using it, and all they came and said is it works like magic, which is, I'm very happy they came and said it works like magic. They have seen many patients, they have treated many patients. Unfortunately, they don't want to publish it because they say we have no time to publish.
Actually, I totally agree that you have, as always, you kind of stimulate us to think differently. And it is not an easy task to change so many concepts that people have been doing for so many years. And it's really creditable and appreciable that you have been trying to hammer your point, and I'm sure it'll go a long way. Now, with this, we come to the next talk, that is what is new in pediatric cataract. We have a Doyen sitting in the chair, and I invite Dr. Ramesh to do this presentation, as Dr. Jaspreet has not been able to come due to illness.
Thank you, ma'am, for that. Yes, let's speak about what's new in management of pediatric cataract. There are some old things which has come up new, and I have classified this talk into 4 segments. One is about the IOL calculation, which all of us are worried. Capsule management, especially the anterior, what's new in that. Implantation in infants is a kind of controversial topic. Where you can implant, we will have some clarity on that, and also the risk of visual axis opacification, which is the very important enemy in pediatric cataract surgery. And also some in terms of systemic association, how genotype, phenotype can help us in identifying. So there are 4 generations of IOL calculation, which is definitely used in adult ophthalmology, but some of them cannot be possible because in children, because of the surgeon factor. We are not able to estimate the anterior chamber depth in most of the patients. So we cannot really extrapolate, but we are implanting the lens against a growing eye. It's a dynamic eye, and we are going to implant there. So these are some of the changes. And if you see the axial length and the keratometer, it grows. The lens also, there is emmetropization process happens. It's different in the less than 2 years, or in toddlers and infants, it's different. So we had, if you look at the axial length, it's different, and also the emmetropization. In 2012, we had looked at multiple formula, specifically in less than 2 years of age. What is the best kind of formula which is never without any prediction error? But it was that we found that SRK2 was most predictable. But if you see this very large series published in 2020 of January, they in fact compared 8 formulas in pediatric cataract patients. So in less than 2-year-old, when the axial length is less than 21 millimeter, that's the most common situation all of us see day in and day out. SRK works, SRK or T formula works relatively accurately, while Barrett and Haggis formula, which you all are familiar, I guess, is better in patients in more than 2 years, and when the axial length is more than 21, provided all of them are cooperative for IOL master. So these are the takeaway in terms of IOL formula calculation. Managing the anterior capsule, all of us have been doing it for the years. But if you ask any ophthalmologist what's the most important thing in pediatric cataract surgery and the most challenging, it's the anterior capsule. Even if you have done many hundreds of adult cataract, still this becomes a challenging issue. But can we use some technology in terms of making it this step easy, which could be cost effective? That's where we try to look at this precision pulse capsulotomy. This is good. It's a good technology. With some riders, it's not possible to use in all the cases. When the anterior and posterior capsule is fine-most, it might even take the posterior capsule also. If there is too much of thick anterior capsule, it may not be useful. In infants, really tiny kids, the capsule can extend. Even if you target for 5.5, the procedure-wise, as you can see in this video, it's not so difficult. It's pretty simple. Anybody who does a cataract, you are able to. It just takes, the whole procedure takes 60 to 90 seconds. We have looked at it. If you are well versed with anticapsular rhexis in children, it takes almost similar or maybe less. In terms of regularity, the borders, everything, it gives a very good strength, much more than the vitrectomy, vitrorhexis, what we do. If you can see the edges of this, when you do the polishing, you can see that sandy kind of accumulation there. But in terms of that, it works very well. And we looked at it. It's a good alternative, especially if you don't have much experience. This can be used in patients, but obviously it's a cost. I suggest if there is a group practice, you can have this portable instrument and buy that license for each of these case. It works very well. But if you ask an experienced pediatric ophthalmologist, it may not make much difference in terms of, I would say the runaway rhexis risk may be almost zero in these kind of cases. The next segment I just wanted to quickly check is the infant IOL implantation, aphakia management in infants. This is a controversy. You know, all of us have gone through this IAD study. The 10-year data also has come. Looking at the clearing visual axis opacity is the most important. If you look at the contact lens group on the right side and the intraocular lens group on the left side, what is the repeat surgery? What happens? If you see in the first year, in the contact lens group, the second surgery risk is almost minimal. But when the child grows, in terms of doing at least one procedure in terms of visual axis opacification or secondary IOL implantation, both are more or less comparable. This is with the high risk of visual axis opacification, what is supposed to be in the IAD study, what is published there. But if you see our publication, it's not so much. It's not, this is one of the paper, I think Mithila is here, one of the first authors. We looked at patients with infants who are less than 6 months. It's available for all of you to read. In less than 6 months, it's 20% versus 74% in IAD study. Risk of visual axis opacification. So if you look at the cost and overall complication between IOL implantation versus aphakia, in terms of visual acuity, no difference. In terms of glaucoma, no difference. In terms of developing strabismus, no difference. But they have seen that the stress of the parents is more, but it may be varying from country to country, because you are at least giving partial optical correction who are patients who are economically underprivileged, all these things. It's always debatable. And if you look at the paper, this is from Dr. Jagatram's group. You can see the outcomes in the primary IOL implantation, a very, very low incidence of adverse events and additional surgery. Similar studies have been published in TAPS. You just remember that this is more than 7 months age. It's not that infants who are less than 6 months. So they also published very good outcome. And also we have our group which published on the long-term outcomes of primary IOL implantation. So having said that, I would kind of put all this together. This is also available for all of you to read. It's a review paper. When to do IOL implantation in an infant, there are certain specific guidelines. You need to look at the preoperative factors, you need to look at the intraoperative factors, and then also socioeconomic factors. Then you can decide for that. Having said that, it's never 100%. It's close to 50 to 60% of the patients we can implant. To overcome that, there are modified lenses to prevent the visual axis opacification. This is one of the patients, probably, yeah, it should run. You can see that this patient had intumescent cataract in a child. We use this precision pulse technology here. You can see that intumescent lens, it just collapses. We were trying to have some kind of collaboration with this bag in the lens. Because of the COVID, it's kind of delayed. So what it needs is the equal sized anticapsular axis and also the postercapsular axis. And then you can take this lenses, bag in the lenses. It is kind of expensive. That's the only limiting factor. In terms of surgery, there is some trick which is required. You need to do 4 or 5 cases to get the hang. This is the lens. This is the bag in the lens, you can see. And if you look at the publication, almost 100% no risk of visual axis opacification with this. You can use your routine foldable injector, and then you need to keep it in the AC and nudge it between the 2 leaflets of the anticapsule and the postercapsule. And this is the tricky thing in the whole surgery once you do the vitrectomy and also put a pilocarpine at the end of the surgery. This is the long-term outcome of this. You can see that in the Schumfleck image, the lens is sitting there, and it has got a very good. The last 2 things, 2 slides. The Delphi study says that it's a group of people who sat together and looked at consensus. When do you implant in unilateral cataract? That's 4 to 6 weeks, and then in bilateral we can wait a little bit more. Before 8 weeks we need to. This is looking at the risk of development of glaucoma versus no glaucoma, because if you do it early, that's the problem. And definitely there is no agreement in the primary IOL implantation, but it has to be taken with the case-to-case basis. And also, definitely, many people ask this question, can I implant a multifocal and toric lenses? Definitely, they are not recommended. And the last slide says about, can we look at the syndromic association? This has to be taken with a pinch of salt, because unless you do a phenotype-genotype correlation, looking at the dysmorphism and other things, you cannot directly advise NGS, that is the next generation sequencing, and you will get the genetic mutation. This has to be used in terms of clinical genotype-phenotype correlation, and then only you must do it. Thank you so much. I would like to take this opportunity to invite you all to the 4th Pediatric Ophthalmology and Strabismus Grand Rounds, which is going to happen in Kolkata in August, and also WSPS meeting in Milan in September. Thank you so much.
Thank you, Dr. Ramesh, for excellent presentation. I agree with Dr. Ramesh that initially we also take that SRK2 formula, and subsequently many switch to SRKT formula. Yeah. And as far as capsulotomy, capsular axis is concerned, I think nothing like hand. But anyway, whether it is a Jefto or whether it is a Femeto, even we have done a study on Femeto. It is same thing whether it is a manual or whether it is Femeto second pediatric cataract surgery, it is the same thing. As far as outcome in the children, in the infant are concerned, I agree. Your study, our study, and many other study shows that excellent outcome even in the first year of life if it is done with care and selectively. Not if axial length is less, don't do. If it is microcornea or microophthalmos, don't do. Excluding that, outcome is excellent. Last comment is that regarding toric, more than 6 years, not less than 6 years, I have used, and because up to 6 years there may be change in the cylindrical number. So we found good result. Thank you so much.
Thank you.
Excellent.
Thank you, Professor Sir, for those pearls. Now I would like to invite the last speaker of this session, Dr. Santosh Honavar. Dr. Honavar needs no introduction in this meeting, and he'll be speaking on what's new on the retinoblastoma. we look forward to you, Hanavasa.
Thank you, Parikshit. I'll be speaking on what are we doing new in retinoblastoma. This slide shows that there's been a dramatic turnaround in the prognosis of retinoblastoma. About 120 years ago, we had 98% mortality. Now we have more than 98% survival. This hasn't happened in any other malignancy except retinoblastoma. Goals are, of course, life salvage, primary goal. Secondary goal is organ salvage, that's eye salvage. Tertiary goal is vision salvage. Tumor classifications have undergone a change. Earlier, we used to use Rees-Ellsworth classification. Then we shifted on to international grouping of intraocular retinoblastoma for ocular prognosis and international staging system for life prognosis. Currently, we have TNM classification as well, tumor node metastasis classification, as we know. But what is really new is the addition of a letter H to it. It is not just TNM, it is TNM-H. H is heritability, bringing into forefront genetics in the management of retinoblastoma. So genetics has come in a big way in the diagnosis, screening and management of retinoblastoma. Trends in focal therapy, we used to use cryotherapy and photocoagulation earlier. Cryotherapy is very effective, but the scar size is much larger than the tumor that you begin with, sometimes producing complications and visual morbidity. Photocoagulation is not recommended because it coagulates the blood vessels which are in the vicinity, and the scar that is produced is much larger than the tumor that you begin with, making it visually morbid. So what we currently use is transpupillary thermotherapy, where the scar is very crisp. It doesn't photocoagulate, it uses the diode laser, of course, but we increase the temperature to about 45 to 60 degrees centigrade to make sure that the tumor undergoes apoptosis. It's not by photocoagulation that the tumor goes away. The scar is very crisp, and the blood vessels that pass through the scar are typically patent. So this can be used for visual conservation. This is a larger view showing that the blood vessels are really patent. What's new in TTT is photodynamic therapy. We use indocyanine green, which is a very easily available dye for the photodynamic effect, especially in tumors which have recurred on a white scar. There is no pigment background to it, so take of laser will be much less in this situation. So when we combine with ICG, you can see that with a couple of sessions, tumor regresses nicely. Plaque brachytherapy is not new. We have very standard indications for plaque brachytherapy. But what is new is the Indian-made plaque. This is as effective as what was available in the West at just less than 5% of the cost. This has helped us conserve many an eye where chemotherapy cannot be done for systemic conditions. For example, the child is not able to tolerate chemotherapy, we can use plaque brachytherapy instead. So conclusion about focal therapy is that less is more, and we're using more visually conservative therapies. In chemotherapy, paradigm change came about in 1996 with systemic chemotherapy. What systemic chemotherapy does is it reduces the tumor to a much smaller scar, thus maintaining visual prognosis. Also, the second principle of chemotherapy is that the tumor always regresses towards its source of blood supply. For example, this was a supratemporal blood vessel that was supplying the tumor. Tumor has regressed towards it, thus freeing the fovea macula very early in the course of treatment, thus maximizing visual potential. Both these advantages are there, but what has changed is the use of chemotherapy in many other forms, such as intraarterial chemotherapy, intracameral chemotherapy, intravitreal chemotherapy, etc. 3-drug intraarterial chemotherapy is an especially useful technique in patients who have group D and E retinoblastoma, where the interventional neuroradiologist would get us access to the ophthalmic artery using a 400 micron catheter. Then we take over and inject a set of 3 drugs right into the ophthalmic artery. What it does is it produces very quick regression of the tumor and a very reliable regression of the tumor. From total retinal detachment, this has regressed to a calcified scar in 3 sessions. Similar example, and this recurrent situation where there was a calcified scar on top of which the tumor had recurred has also regressed. So IAC is extremely useful in group D and E retinoblastoma. It adds to about 10% in terms of eye salvage over and above what systemic chemotherapy does, and also for large recurrences. Vitreous seeds were always a bugbear. Now we have an extended classification of intraocular seeds, not just vitreous, but prehyaloid, subhyaloid, epiretinal, intraretinal, and subretinal based on OCT, intra-EUA OCT, and also intracameral in the anterior chamber. They have been further categorized as depository and infiltrative. How do we treat them? Once the retinal tumor has nearly regressed with chemotherapy, we treat the intraocular seeds by using intravitreal chemotherapy, safe intravitreal chemotherapy. We started off using melphalan, which gave us good results, but melphalan also produced complications in pigmented eyes because it causes RPE changes. As you see here, extensive RPE changes in this patient. It causes uveitis, cataract, needs weekly injections, which makes it logistically difficult. So we shifted over to intravitreal topotecan. This was used for the first time. And then you can see nice results with topotecan. It's very friendly to the retina, and the seeds go away after 2 or 3 injections. These are some of the examples of combining topotecan with low-dose melphalan in refractory situations. Worked well, and in initial series we got 100% success, but now we have about 90 to 95% success because we are taking difficult cases for this treatment. What are the extended indications? Earlier, we would enucleate eyes with anterior chamber seeds mercilessly. Now we have intracameral chemotherapy and intravitreal chemotherapy. This patient with anterior chamber seeds, which were depository, that come through the zonules into the anterior chamber without any involvement of the ciliary body or the trabecular mesh work. How do we confirm that? We do a UBM under anesthesia and confirm that. Then we inject intracameral topotecan. It has no corneal endothelial toxicity, and the seeds go away. In patients who have ciliary body invasion, of course, we use intracameral topotecan. Along with that, for the ciliary body component, we do plaque brachytherapy. You can see nice regression of the ciliary body component and also nice regression of the seeds with this technique. For seeds which are within the retina or epiretinal seeds, earlier we would do laser and that would produce scar, and now we use the same intravitreal chemotherapy to regress that as well. So that has also been taken care of. Enucleation technique has been standardized, but what was realized is that about 20 to 30% of children died despite enucleation. That's because they had histopathological risk factors which were either identified and not taken care of or not identified. These are anterior segment invasion, ciliary body invasion, choroidal invasion more than 3 mm in thickness and diameter, and optic nerve invasion beyond the lamina cribrosa, all of which now receive adjuvant chemotherapy. The advantage is that if you don't give adjuvant chemotherapy, 24% children would die, whereas if you give adjuvant chemotherapy, you can save about 20% more children. So it gives a survival benefit of 20% just by this simple therapy. So enucleation is not the end in clinical management. In orbital retinoblastoma, which either you identify by clinical evaluation or by MRI, as you see here, we have a protocol of multimodal management, which produces much better success. From 70% mortality, which we had earlier, now we have about 90% survival. This is an example of a patient with orbital retinoblastoma. After neoadjuvant chemotherapy, orbital component has regressed. Then you do a enucleation with a long optic nerve stump, provide stereotactic radiation and adjuvant chemotherapy as well. It works for optic nerve invasion. You can see optic nerve caliber having returned to normal following neoadjuvant chemotherapy. Intracranial extension, which were earlier managed only with palliation, giving up on them, now is possible to take care of by neoadjuvant chemotherapy. After neoadjuvant chemotherapy, all this has regressed, and all that is left is the superior orbital fissure, which is amenable to stereotactic radiation. Cosmesis is a definite bonus in these patients. We don't do orbital exenteration anymore. We do multimodal treatment and fit them with a very cosmetically gratifying custom ocular prosthesis. This is one more example of a patient where we could avoid orbital exenteration and cosmetically rehabilitate the patient. Of course, they would lose the eye. So orbital RB also now has a cure. With all this put together, our survival in India is very close to what we see in the West, nearly 95% life salvage. So in conclusion, I would say that retinoblastoma management remains complex, but what we now do is customized care depending on the clinical situation with cost-effective protocol-based techniques. Thank you so much.
So we are thankful to the audience. We are thankful to all the speakers and my colleagues on the dais. Thank you very much. This is the end of the session.